Hey, welcome back. Let's start with the male excretory ducts and glands, and we begin in the epididymis. And as you can recall, it's a lot of like coiled coils of a duct, and it's all enclosed in a loose vascular connective tissue. So it's very well nourished, and it rests on the testes, and it's composed of a pseudostratified columnar epithelium. So as you can see here, there's not really any stratification. It's just very jagged, I want to say. And then on the inner lumen is going to be your stereocilia, and inside is the sperm. So the principal cells have a lot of the stereocilia, so it's very, very fine cilia. It's not microvilli because these are not absorbing anything. And there's a lot of organelles along with something called like the pinocytotic vesicles. And though the stereocilia aren't really there to absorb fluid, it does have a function in absorbing and secretion of the glycolipids, along with a lot of enzymes that allow the sperm to mature and for the sperm to like kind of absorb and then help deposit those enzymes onto the female genital tract in order for other reactions to occur. So, GDF will bind the cell hormones and block the acrosomal reactions and the fertilizing abilities until all of the factors are removed, and that only occurs in the female productive tract. So, the GDF cells are, or the principal cells, they have a phagocytic role as well. So, they will consume the damaged cells along with any kind of pathogens it encounters. And there is going to be the basal cells, and those will be sandwiched between the basal membrane and the basal lamina or the lamina propria. And then here are the columnar cells. This is the pseudostratified layer. And then the basal cells will proliferate in order to replace the other cells. Here's your stereocilia. And the cilia will beat in order to move the sperm. So the muscularis is going to be smooth muscles, and there are an inner and outer layer, and until it reaches the tail. So the tail will get an extra layer, and it's going to be circular. The contraction occurs due to the movement occurs due to the contraction of the circular layer. And it takes about 10 days for the spermatozoa to reach the tail of the epididymis, and then it's stored there for about like 4 months. And then the tail doesn't contract, the tail of the epididymis, not the sperm, I should say. It doesn't really contract until the sympathetic system is stimulated, and that's during the ejaculation phase. So they contract with the ductus deferens. So here's the smooth muscle, here are the sperm mass, here's the fascicles of the cremaster. So this will like raise the testes and they contract during ejaculation, and then all of this is going to be expelled. So what does the epididymis do? It allows the sperm to mature and to mobilize. There are going to be glycoproteins and sialic acid to nourish the sperm. And there's going to be phagocytes, of course, and it transports during contraction. Here's the caput or the head. This is where the fluid reabsorption occurs. The corpus is where the motility occurs, or motility is acquired. And then the tail is where things are stored. Okay, so what happens in an infection? Usually it's by some kind of STI. So it can be caused by gonorrhea or chlamydia. It's going to be characterized by interscrotal pain, persistent inflammation, tenderness. There can also be some heat. In bad cases, it can lead to hydrocele. And hydrocele is where the fluid is going to be trapped in the tunica vaginalis. And there's going to be compression of the testicle along with heat retention and it could also make the epididymis fibrotic, and that can lead to infertility, of course. So in this H&E size, as you can see, like all these cells are or the sperm masses are packed like too closely together. There's no room for them to expand and grow, and it's going to be also like very hot, due to the increased like retention of water. So next is the Ductus Deferens, and it's just going to be a conduit, and it begins at the end of the epididymis and goes up, and then it's going to go through the inguinal canal and enlarge at the distal end and make something called an ampulla. And the ampulla is like a little opening, or like a little cavity, I want to say, and there is going to be two of them because two testes, they join together to make the ejaculatory duct along with the seminal vesicles, which are like right back here. So here, right here's the ampulla, here's the seminal vesicle, and all of that will open into the prostatic urethra, so the very beginning of the urethra. As you can see here, this is the root of the sperm. So begins in the testes, goes into the epididymis, up to the vas deferens, into the seminal vesicles, and then into the through the prostate into the urethra. So there's, as you can see here, here's the ampulla, and here are the seminal vesicles, and all of that leads into, along with the ejaculatory ducts, and it all leads into the urethra. There are going to be layers of tissue that are continuous with the abdomen to kind of hold these structures in place and protect them from any kind of injury. And then the wall of the ductus deferens is going to be like two layers again. It's going to be the longitudinal folds, and they become more irregular in the ampulla, and the pseudostratified columnar epithelium is going to be there along with the principal cells, with the stereocilia and the basal cells, of course. But unlike the epididymis, there's not going to be as much because it's more like peristaltic contraction that move the sperm, not just the cilia. So the muscularis is going to be your muscle coat, and it's going to be thicker than in the epididymis, and there's going to be 3 layers this time. It's going to be a longitudinal, a middle circular, and an outer longitudinal, and then the tail has an extra circular layer. Okay, so in surgery, sometimes you need to look for the spermatic cord, and in the inguinal canal, you can actually palpate it. It's kind of, it feels like a rolled cigarette, and that's due to the muscles, and of course they contract during ejaculation due to the sympathetic activity, and the muscularis is thinner at the ampulla because it's more for like storage, and then the longitudinal layers will disappear towards the ejaculatory duct, and while it's replaced by the adventitia, it's going to be denser. And in the ejaculatory duct, it's going to be lined with the pseudostratified columnar epithelium, more for protection against like the high velocity of the sperm and the semen being like expelled. Okay, so vasectomy is just pulling out the vas deferens, cutting them or ligating them or tying them depending on what the patient wants, and it's a form of sterilization for men. Okay, so the seminal vesicles are going to be glands, and they face backwards, interestingly enough, and they produce only semen. They don't store any sperm, and of course they all come together in order to join the prostate, or join in the prostate urethra. So the wall of this is going to be very folded, like you see here. The lumen isn't very wide at all, and they are going to be made of pseudostratified columnar epithelium. There's going to be a lamina propria and smooth muscle, of course. And the principal cells have no stereocilia, and they work as the secretory cells, of course, because they don't store any semen. So why have stereocilia, right? At the top of the cells, they're the secretory vesicles, and there are going to be two layers of muscle this time. It's going to be a thin inner circular layer and then an outer longitudinal layer. So kind of when you move through the duct system, and this one will have, like, it loses the inner longitudinal layer of the previous structure, and it only retains, like, the middle layer and the outer longitudinal layer. So these also contract, of course. So seminal vesicles, their main function is just semen production, and this semen component is alkaline, and it contains fructose as well. So this fructose is really used in forensic science in order to see if a victim has been raped or if there has been semen left at the scene, because the fructose is the one that really lights up in black light. So prostaglandin is also secreted by the seminal vesicles, and that is going to suppress the immune response against semen in the woman and also thin the cervical mucosa, because remember, the cervical mucosa is very thick in order to prevent sperm going in. So it also plays a role in stimulating smooth muscle contraction in the woman. Seminogelin is going to be the protein for coagulation, and it inhibits the motility, just kind of like holding the sperm in place in the female genital tract in order for the capacitation reaction to occur. And then it's degraded by PSA to liquefy the semen. Once the sperm has been capacitated, it needs to get out of the coagulated semen. So this will help. Inositol will regulate the calcium needed for capacitation, and then, like I said before, the flavins in the fructose will be the fluorescent pigments. Okay, so the prostate is going to be the largest accessory sex gland, and it's surrounded by a fibroelastic capsule, and it extends septa that divide into the lobes, and then the prostatic sheath is going to be the visceral layer of the pelvic fascia. So the prostatic fascia is going to be the false capsule, because the prostatic sheath is like the real capsule or the true capsule. And all of this has the prostatic venous plexus and the nerves, and they all lie between the prostatic sheath and the fibrous capsule. So it lies between the true and the false sheaths. And in addition, it has a lot of tubuloalveolar glands, and that is really embedded in the muscle. So the fibromuscle stroma will contain the glands along with the muscle fibers and whatnot. The skeletal muscle is going to be more towards the apex of the gland, and that merges with the fibromuscular tissue of the urogenital diaphragm. And that's important because this will block the reflux of urine, or it will allow the semen and the sperm to come out without mixing into the urine. Okay, so the epithelium of the prostate, of course, there's going to be those tubuloalveolar glands to make part of the semen, and it's all lined with this pseudostratified columnar epithelium, and those will also work as secretory cells. If you ever see like cuboidal or columnar mentioned in the epithelium, they are always like secretory cells. The ducts are going to be lined with the simple columnar epithelium, and then that changes into the transitional epithelium towards the opening of the urethra. There's no secretion there. So there's about 15 to 25 ducts that merge into the epithelium, and all of that empties into the prostatic urethra. The epithelium is going to be surrounded by the lamina propria along with the smooth muscle, and then the secretory alveoli will make the folds of the lumen. So here are the acinar cells. These are the secretory cells. Basal cells will proliferate to replace the acinar cells if they are damaged or old. Okay, so there's 3 zones of the prostate. There's going to be the peripheral, which is most of the glands, and that is fortunately resistant to hyperplasia, so resistant to cancer, but it is susceptible to inflammation. Makes sense? It's the outermost layer or zone. The transitional zone will have some of the glands, and this is really the site of benign prostatic hypertrophy. And so in elderly men, this is more prominent. The periurethral is the innermost zone, and it contains the mucus gland to protect the urethra from the acidity of the urine. And then this, unfortunately, is the first zone to be affected in malignancies, of course, because there's toxins in the urine. Okay, so benign prostatic hypertrophy, it will compress the submucosa glands along with the other glands and the fibromuscular component as it gets worse. And it occurs in years. And eventually it will compress the bladder and compress the urethra. Patients will complain of frequent urination, especially at night, and the stream is weak, it would be dribbling out. And that's how they can't fully empty their bladder, and it's very uncomfortable. Fortunately, we can treat it, so yes, there is a fix for this. So as you can see here, the hyperplastic glands are going to have all these very large papillary infoldings, and they're lined with this double layer of epithelium. Inner is going to be columnar, outer is going to be cuboidal. Outside is the corpora amylacea, and then all of this is embedded in the fibromuscular stroma. And we can tell that it's the benign prostatic hyperplasia because the lumen is very large. Look, it's kind of compressing with each other. Oh geez, skipped a little bit too much. Okay, so the corporal amylacea are going to be deposits of glycoproteins and keratin sulfate that has calcified, and they form these neat little ring structures. And they don't really do anything. They just are a good they're just a good indicator that whatever tissue you sampled is going to be a prostate, and it's the peripheral zone of the prostate. Okay, what does the prostate do? It makes a decent chunk of the seminal fluid, and it's going to be an acidic part of the fluid. So remember we were talking about the vas deferens and the glands, the ejaculatory glands and whatnot. Those make the alkaline fluid. Well, this one makes the acidic fluid, and it's only mildly acidic. Semen is definitely more alkaline than acidic, but it has the hormones along with citrate and zinc and some fibrolysin and the PSA. And the PSA is an important indicator. The prostate it's increased in prostate cancer, along with trauma and inflammation, and we really do check it in a clinical scenario to see if this patient will have prostate cancer, because it will have acid phosphatase as well. Was a rise in the PSA, and then checking the citrate and zinc levels, they're going to be high in the peripheral zone, but then they're going to be decreased in prostatic cancer. But we use the PSA to really differentiate between the benign hypertrophy or hyperplasia of the prostate and actual prostate cancer. Okay, so the accessory glands are all the way down here, and they will make 90% of the semen, and 10% of the spermatozoa are going to be made. And we've checked the function of the accessory gland because the semen should liquefy within 30 seconds after ejaculation, and if it doesn't, it can indicate an infection. So this is kind of the percentage of what the glands secrete. The glands are going to be part of it is going to be the epididymis, and then the seminal vesicle. This is the one that secretes the alkaline part of the semen, and then the prostate, which secretes the acidic portion. Okay, so the Cowper's glands are also known as the bulbourethral glands, and they are found right here in the urogenital diaphragm. They also have a capsule of dense tissue or connective tissue, and they have lobes, and they empty into the penile urethra in the corpus spongiosum. So like we've already reached we've reached past the prostate and into the actual like penis. The glands are tubuloalveolar, and they secrete mucin, and that will lubricate and clear the urethra. Okay, so the penis itself is made out of the paired corpora cavernosa. These are very well vasculated, along with the corpus spongiosum. So the corpus spongiosum is the actual thing that the actual component that contains the urethra. These two corpora cavernosa really convey a lot of veins, capillaries, and artery. All of this is going to be surrounded by the tunica albuginea, and the one ventral corpus spongiosum is there. Buccal fascia is going to be the skin, and that surrounds the penis, and it allows the shaft of the penis to move free, or the skin of the penis to move freely along the shaft. It's going to be mobile. It contains a Ductus muscle, and that allows for the filling of the penis during erection. And inside the penis, there's going to be a lot of like cavernous spaces to store the blood, and it's lined with the endothelium and separated by all these connective tissues, smooth muscles, and whatnot. So inside the corpus cavernosa is going to be like one big cavernosa artery, and right here is going to be the urethra. Okay, so what is the urethra? It's a fibromuscular tube. The mucosa is going to be a transitional epithelium, and it lies on a very loose, vascular, descensible lamina propria, and it's folded like this in order like whenever you urinate and contract everything, this can stretch to accommodate the urine coming out, or stretch and widen so the stream would be strong. So the male urethra has 3 parts: the prostatic urethra, the membranous urethra, and then the penile urethra. And the external urethromuscular sphincter is going to control all of that. So the important thing to note is the external urethral sphincter, even though it says external, is not at the very tip of the penis. It's not at the glands. It's near the diaphragm, so like far up, near towards the bladder. And we call it external because the only external portion of the male genital tract is the penis. The female, not so much. So the lumen in men is going to be stellate, but in female is more in a moon shape. So the urothelium will also line the prostatic urethra, because that's like the start of the actual urethra, right? It's going to be a stratified, properly stratified this time, columnar epithelium, and the penile urethra towards the end, and the female urethra, the entire tract, is going to be lined with a non-keratinized stratified squamous epithelium. So there is a transition in the males only. Females, one shot, go. And then the leader glands are going to be small mucus glands in the lamina propria of the penile urethra. And then the Skene's glands are going to be in the vagina around the lower end of the female urethra. So more towards the outside. Okay, so that's it for now. Thank you for your attention, and good luck studying.